Hello everyone, and in today's video we are going to cover dyslipidemias. This is the dyslipidemia portion from endocrinology. In the previous video I told you that there are two portions of endocrinology of dyslipidemia. One is in from family medicine, the other one is in endocrinology. This objective of MCC, that says abnormal lipids, let me just show you. Abnormal lipid has two components. So if you type MCC objectives, you will have this website. You get into medical experts here, and then from medical experts you see MCC objectives. In MCC objectives, you have to learn about abnormal lipids. In this video, that's what we are doing. So abnormal lipids is divided into two chapters in Toronto notes. One is in family medicine, the other one is in endocrinology. Endocrinology part is that's what we are doing right now. The family medicine part is already covered in the previous video. I'll try to link down in the video today. So let's cover dyslipidemia from endocrinology. So then only your abnormal lipids portion or MCC objective would be covered if you cover it from both chapters. So that's how you have to do. You have to open the MCC objective. You have to see. Let's see, how did I know? I got to know because from family medicine they have mentioned E3 in family medicine chapter. So E3 means endocrinology 3. So once we open E3 in Toronto notes, you will see another dyslipidemia topic here. So let's continue. Dyslipidemia is a metabolic disorder characterized by elevation of the fasting plasma LDL-C and or triglycerides and or low HDL cholesterol. So dyslipidemia has three components in it: LDL-C, triglycerides, or low HDL. If someone has low HDL, dyslipidemia. If someone has high triglyceride, dyslipidemia. If someone has high LDL-C, dyslipidemia. So overview of lipid transport. Lipoproteins are spherical complexes that consist of lipid core surrounded by a shell of water-soluble cholesterol, apolipoproteins, and phospholipids. Lipoproteins transport lipids within the body. Apolipoproteins serve as an enzyme cofactor, promote clearance of the particles by interacting with cellular receptors, and stabilize the lipoprotein micelle. So there are two different components: lipoprotein and apolipoproteins. Apolipoprotein serves as an enzyme, and lipoprotein serves as a transporter within the body. So these are different types of lipoproteins. Chylomicrons transport dietary triglycerides from the gut to adipose tissues and muscles. VLDL transports hepatic synthesized triglycerides from liver to adipose tissue and muscles. IDL products of hydrolysis of triglycerides in VLDL by lipoprotein lipase, resulting in depletion of triglyceride core, enriched in cholesterol esters. LDL cholesterol rich atherogenic particles formed by further removal of residual triglycerides from ideal core by hepatic lipase. HDL transport cholesterol from peripheral tissue to liver, act as a reservoir for apolipoprotein. Now, moving forward, if you see this exogenous endogenous biosynthetic pathway, so this is something that you can use to learn the table above. So you can see chylomicrons are the ones which transport dietary triglyceride from the adipose tissue to the adipose tissues and muscles. So you have to figure out you see these chylomicrons, these are transporting triglycerides from the liver to the muscles and the adipose tissue. So you can figure this picture out and have a good concept of your dyslipidemias. But moving forward, what is the most essential part on this chapter or this portion of dyslipidemia that you need to learn for QE1? So primary dyslipidemias are rare and they are genetic defects in the lipid metabolism. So this is the most important table that you have to learn for QE1. The previous part, anything that we have read so far, is not something that I've witnessed in exam so far, or I have heard anyone telling me about that. But this part is the primary dyslipidemia table is important. Why? You need to know familial hypercholesterolemia has high total cholesterol, high LDL. What is the mechanism? Genetic defect in LDLR is the most common, PCSK9 and ApoB. And it is an autosomal dominant condition that can be homozygous or heterozygous, impacts liver ability to clear LDL from circulation. What are the clinical features of it? It causes tendinous xanthomas, Achilles patellar and extensor tendon of hand, arcus cornealis, xanthillus meta, heterozygous premature coronary artery disease, 50% risk of MI in men by 30, homozygous manifest coronary artery disease and other vascular disease early in childhood, which can be fatal in less than 20 years of age. So it's a fatal condition. It's a serious condition. Okay, it's an autosomal dominant genetic disorder where there is high total cholesterol, high LDL, and this is known as familial hypercholesterolemia. What is the treatment? Maximally tolerated statin as initial drug therapy. Addition of second drug, ezetimibe PCSK9 as second line, third line of homozygous portocable shunt or LDL apheresis. Potential liver transplant, refer to lipid specialist in drug resistant hypercholesterolemia. So it's a serious condition where you have to give high dose of statins. You can consider doing ezetimibe, you can consider doing PCSK9, and the clinical features are similar to what we see in atherosclerosis, like in hypercholesterolemia, but it's a condition where premature coronary artery disease are common. 50% risk in men by 30, and less than 20% and less than 20 years of age are at risk for coronary artery disease. The other one is familial combined hyperlipidemia. What is the difference between this and the other one? The familial hypercholesterolemia just has total cholesterol and LDL, but familial combined hyperlipidemia has triglycerides, LDL, and ApoB. It doesn't have total cholesterol, but it has triglycerides and ApoB instead of total cholesterol. So increased production of ApoB 100 containing lipoprotein from liver, premature coronary heart disease, xanthelasma, and obesity are the clinical features. What do? You give statin as initial therapy, addition of ezetimibe, PCSK9 if LDL lowering is not achieved. May consider fibrates if elevated triglycerides. So fibrates is mostly working on triglycerides. Polygenic familial hypercholesterolemia, LDL is raised only. Mild effects in multiple genes are responsible for LDL metabolism, LDLR, ApoB, ApoE4. Higher risk of cardiovascular disease similar to familial hypercholesterolemia for patients older than 40, but it comes with risk in older than 40. But that one, familial hypercholesterolemia, comes with risk factors in the earlier age, less than 20. By 30, it's 50%. The risk is 50%. Treatment is similar: statin, ezetimibe, PCSK9 inhibitors, nicotinic acid as alternatives if not tolerated or in addition. Now, hereditary chylomicronemia, familial lipoprotein lipase deficiency. Example is familial hypertriglyceridemia, type 4 familial dyslipidemia, ApoC2 deficiency. So these are different names for hereditary chylomicronemia. Hereditary chylomicronemia has increased triglyceride from excess chylomicron particles. Lipoprotein lipase deficiency, this is the enzyme deficiency. The above three were the genetic problems with increased productions of certain type of lipids, but this one is a deficiency of the enzyme that is known as lipoprotein lipase. Prevents proper digestion and storage of fats, leading to massive accumulation of triglycerides rich chylomicron particles. ApoC2 deficiencies prevent activation of lipoprotein lipase, leading to massive accumulation of triglyceride rich chylomicron particles. Present in infancy, adolescence, and adulthood. Abdominal complaints like pain, hepatosplenomegaly, pancreatitis, lipidemia retinalis, eruptive xanthomas. Less than 10 to 15% of calories from fat. The treatment for this one, hereditary chylomicronemia, is reduction of fat intake. Supplement with essential fatty acids, fat soluble vitamins, plasmapheresis may help individuals with ApoC2 mutations. Familial hypoalpha lipoproteinemia has less low HDL, and it's an autosomal dominant inheritance of ABCA1. You don't have to remember this, you just need to remember that it's an autosomal dominant condition and it has low HDL. The name is familial hypo alpha lipoproteinemia. That's it. You don't have to get into the details. What is the treatment? The presentation would be premature atherosclerosis, cerebrovascular disease. Reduce the risk of atherosclerosis with lifestyle changes, management of concomitant hypercholesterolemia, hypertriglyceridemia, and metabolic syndrome if present. Dangerous disease is low HDL. So that one also had low HDL. This one also has low HDL. What is the difference? The above, the one that we discussed above, has is autosomal dominant, but this one is autosomal recessive, inheritance of mutation, and so on and so forth. You just have to remember that it's an autosomal recessive, low HDL, Tangier disease. Mild hypertriglyceridemia, neuropathy, enlarged orange-colored tonsils, premature atherosclerosis, splenomegaly, hepatomegaly, corneal clouding, type 2 diabetes mellitus. The treatment would be reduce the risk of atherosclerosis with lifestyle changes, management of concomitant hypercholesterolemia, hypertriglyceridemia, metabolic syndrome if present. So you don't have to really treat it. You just have to tell the lifestyle modification. You have to emphasize on metabolic syndrome and so on. So familial hypoalpha lipoproteinemia, low HDL, autosomal dominant. Tangier disease, low HDL but autosomal recessive. Hereditary chylomicronemia, high triglyceride, deficiency of lipoprotein lipase. Polygenic familial hypercholesterolemia, high LDL, and you have to treat with statins. The above three you have to treat with statins, and then so on. You have to just give emphasize on dietary restriction and lifestyle modification. Familial combined hyperlipidemia, high LDL, high triglycerides, high ApoB. Familial hypercholesterolemia, high total and high LDL cholesterol. So this is the table that you have to remember. Moving forward, secondary dyslipidemia caused by acquired medical condition or lifestyle factors that affect lipid metabolism. What are the secondary causes of dyslipidemia? Hypercholesterolemia. Now they have divided into three different, because in the definition of dyslipidemia we did learn that high cholesterol, low HDL, high triglyceride is dyslipidemia. So what are the three different causes of three different types of dyslipidemias? One is if there is hypercholesterolemia, the causes are endocrine like hypothyroidism, small dense LDL with type 2 diabetes, obesity with normal LDL levels. So hypothyroidism, nephrotic syndrome, CKD, monoclonal gammopathy, cholestatic liver disease like primary biliary cirrhosis, anorexia nervosa, cyclosporin, carbamazepine, steroids, smoking, and obesity. Then in low HDL you have to remember obesity, metabolic syndrome, diabetes, drugs, beta blocker, anabolic steroids, and acute infections, inflammatory conditions. Hypertriglyceridemia is caused by obesity, metabolic syndrome, diabetes. Nephrotic, CKD, steroids, estrogen, hydrochlorothiazide, retinoic acid, beta blocker, without intrinsic sympathomimetic activities, antiretroviral drugs, atypical antipsychotics, oral contraceptive pills. Lifestyle causes are alcohol, high carb diet, high fat diet, and pregnancy. Now, what do you think you might have to learn from this one? Things you have to learn from this one is the drugs. Most important one, drugs. Most important one, lifestyle. You have to remember which one is causing which one. Let's say alcohol is causing hypertriglyceridemia, but alcohol is not causing low HDL or hypercholesterolemia. Hypertriglyceridemia, alcohol. High carbohydrate hydrate diet, high fat diet, hypertriglyceridemia. Pregnancy causes hypertriglyceridemia. So these are the unique things that you have to remember for each one of them, right? So common things, that diabetes, CKD, nephrotic syndrome, obesity, metabolic syndrome, but you have to remember the unique things because they test you on unique things. Hypercholesterolemia is caused by anorexia nervosa. So if someone is having psychiatric problem, anorexia nervosa, they may have hypercholesterolemia because of that. Primary biliary cirrhosis have hypercholesterolemia. So that's what you have to pick and learn. Okay. In hypertriglyceridemia, you need to remember pregnancy does cause hypertriglyceridemia. Okay, and the name of the drugs is most important. Like you see, hypertriglyceridemia has this unique thiazide, retinoic acid, beta blocker. These are unique for hypertriglyceridemia. Likewise, hypercholesterolemia has cyclosporin, carbamazepine, and steroid. And then this one has beta blocker and anabolic steroid. So that's how you remember it. Okay. Now on the right side, this small box shows familial hypercholesterolemia and cardiovascular risk calculator. Risk calculators such as Framingham and score do not apply to patients with familial hypercholesterolemia. Consider all adults with familial hypercholesterolemia at high risk. Okay. So we don't use this FRS score. Remember, we learned in the family medicine chapter in the previous video that FRS score is the one that we are using to calculate if we need to prescribe the patient is at low risk, high risk, or moderate risk, or if we need to prescribe statins or not. Okay. So treatment effect, each 1 millimole per liter decrease in LDL corresponds to approximately 25% relative risk reduction in cardiovascular disease. Statin lower LDL by 30 to 40%, ezetimibe lower LDL by 18%. You need to remember these percentages as statin is the most effective one, then ezetimibe, and then PCSK9. In the previous video, we learned about the management and we did read that 10% of lifestyle modification will reduce the cholesterol by 10%, 40% is the medication that is affected, right? 6% rule, if the dose of statin is doubled, there is approximate 6% increase in LDL lowering efficacy. Okay. So, dyslipidemia and the risk factor for coronary artery disease. Increased LDL is a major risk factor for atherosclerosis and coronary artery disease. That's what we all know. Increased HDL is associated with decreased cardiovascular and mortality. Moderate triglyceride is an independent risk factor for CAD, especially in people with diabetes and in postmenopausal women. So, moderate triglyceridemia is a risk factor for patient in diabetes and postmenopausal. HDL increase is causing reduction in mortality. increase LDL is a risk factor. Screening: men and women more than 40 years or postmenopausal women, you have to screen for lipid profile. If the following risk factors are present, like diabetes, smoking, or COPD, high blood pressure more than 140 by 90, hypertensive disease of pregnancy, obesity more than 30 BMI, family history of premature cardiovascular disease, dyslipidemia, clinical features of hyperlipidemia, xanthelasma, xanthomas, or arcus carnialis, clinical or radiological evidence of abdominal aortic aneurysm, clinical evidence of atherosclerosis, inflammatory disease like rheumatoid arthritis, SLE, psoriatic arthritis, because these are all autoimmune diseases. HIV infection or highly active antiretroviral therapy, CKD, erectile dysfunction, because one of the cause of erectile dysfunction is hyperlipidemia, high risk ethnicity like South Asians and indigenous people. Screen children with a family history of hypercholesterolemia or chylomicronemia. Components of screening: history and physical examination, lipid panel, total cholesterol, LDL, HDL, triglyceride, non-HDL cholesterol, and blood glucose level, EGFR. So these are the components that you are going to order. So let's see if there is a 40-year-old male, healthy, all no family history of cardiovascular conditions, nothing. What are you going to order? You will order screening. Why? Because he is 40 years of age. Then that's the cutoff that they are telling us to do. So these are the workup that you will order. And optional is urine albumin creatinine ratio and ApoB. ApoB is each atherogenic group of VLDL, IDL, LDL lipoprotein contains one molecule of ApoB. Serum ApoB reflects the total number of particles, may be useful in assessing cardiovascular risk and adequacy of treatment in high risk patients and those with metabolic syndrome. Lipo A levels may help certify those with intermediate risk but not recommended for routine measurements. Coronary artery calcium may help certify those at intermediate risk. CRP levels, highly sensitive acute phase reactant, may be clinically useful to identify those at higher risk of cardiovascular disease than predicted by global risk. So that's not something that we need to focus on. Framingham risk score, we have already done it in the previous video. I'm just quickly gonna review it. But I think on the right side there's a box for statin follow-up. Liver enzymes and lipid profile. Liver enzymes measured at the beginning of the treatment, then once after the therapy initiated. Why? Because statin causes myalgias, rhabdomyolysis, and may increase the creatine kinase levels. Lipids, once stabilized, measured annually. So you have to first initially measure them at 6 weeks, and then 3 months, and then 6 months, and then once everything is stabilized, you will measure it annually. Order both if patient complains of jaundice, right upper quadrant pain, dark urine. Creatinine kinase at baseline, and if the patient complains of myalgias, then only. Okay. Discontinue statins if creatinine kinase is more than 10 times upper limit of the normal, or patient has myalgia. Patient has symptoms, or the CK level has gone more than 10 times. If CK level has gone more than 2 to 3 times, the patient is not symptomatic, continue the treatment. Okay. CK level at the baseline, and if the patient complains of the symptoms. Now moving on to this treatment dyslipidemia approach, which we have already covered in the previous video, but I'm going to quickly go over on this. So we use FRS score. On FRS score, and I have shown you in the previous video that what FRS score is. Let me quickly show you over here as well. Okay, so anything that you're not sure in the book, make sure you open Google and check on that, right? So this is the FRS score. We put age, we let's say put male, let's say he is a 60-year-old male, he is a smoker, his total cholesterol is let's say 210, and his HDL is let's say 70, and his systolic blood pressure is 135, and his blood pressure is treated with medication, so he is at 14.4 10-year risk of MI. So 14.4 means the patient is in the intermediate risk. So that's 20. Instead, he is at high risk now, okay, because of his age, his smoking, and his blood pressure. So if the patient is at low risk, the FRS is less than 10, intermediate risk is 10 to 19, and high risk is more than 20. FRS is if let's say in the intermediate range, the LDL is more than 3.5. So you have to discuss the lifestyle modification and statin therapy. Statin therapy is indicated for those with high risk or those with an additional condition. Okay, so statin therapy not recommended for most in the low risk individual. Exceptions, there is exceptions for those. Let's say if LDL is more than 5, then statin is indicated. FRS is 5.9 with LDL more than 3.5. So if LDL is high, let's say risk is low, still we will give statins. Okay, so lifestyle modification and health behavior modifications are smoking cessation is on the top. This is what I've told you in the previous video as well. Anything that they have mentioned on the top, make sure you learn it on the top priority. Let's say smoking cessation, lifestyle, diet. If they ask you in a question, smoking cessation is the first thing that you will talk about in the patient with dyslipidemia. Smoking cessation, then you'll talk about diet, and then you will talk about exercise. How much exercise? At least 150 minutes per week, moderate to vigorous intensity aerobic physical exercise. You need to know this as well. Okay, then how would you monitor? So once you've started patient, let's say if intermediate or high risk patient, you've started him on treatment of statin, you have started him on 10 milligram, then you will reassess him in 3 months and see if his cholesterol is going down. It should go down by 50% or it should come less than, let's say, 2 millimoles. If that's not the case, then you have to upgrade, like maximally tolerated statin dose you have to give high dose. If after giving high dose the cholesterol is not going down, then you have to consider add-on therapy. What two add-on therapy are you considering? One is ezetimibe, the second one was PCSK9. Okay, so then you will monitor response to statin, respond to add-on therapy, and health behavior changes. So these are the combination of three things that you're going to do. Statin indications are LDL more than 5, or most patients with diabetes with more than 40 years of age, more than 30 years of age, but more than 15 years of diabetes, with microvascular conditions, or patients with diabetes with CKD, or their albumin creatinine ratio is more than 3 or GFR is less than 60. Patients with hypercholesterolemia and their LDL is more than 5, then you have to give statins. Atherosclerotic conditions like MI, acute coronary syndrome, angina, TIA, peripheral arterial diseases, claudications, ABI less than zero point 0.9, abdominal aortic aneurysm of more than 3 centimeter or previous aneurysm surgery. These are all high risk. You have to give statin. So you have to give statin, initiate statin, and LDL-C if more than 2.5. Then you have to discuss or add-on therapy. If in intermediate risk LDL is more than 2, you have to again discuss add-on therapy. And if LDL-C is less than more than 1.8 in a high risk patient, then you have to intensify the therapy. So these are the following: the yellow one is intermediate one, the green one is a low risk one. For each of them the ranges is different. The more high risk it is, the lower LDL we are considering. Okay, so let's say the high risk one, the one in pink on the right box, it says if LDL-C more than 1.8, that means it's not much, but the patient is at high risk, so we have to consider even 1.8 is high for that patient, right? So we have to intensify the therapy. Refer figure treatment intensification approach. And for the intermediate and low risk one, discuss add-on therapy with the patient. Add-on therapy are ezetimibe and PCSK9, and then you have to monitor the response every 3 months. Once patient is stabilized, you will then shift to 6 months or 1 year. Patient with atherosclerotic diseases 1.8 or triglyceride more than 1.5. So this is another drug that you have to consider for more than 1.5 triglyceride, that is icosapentile ethyl 2000 milligram BID. So first drug was statin, second drug was ezetimibe, third drug was PCSK9, and the fourth drug is icosapentile to ethyl 2000 milligram BID. Okay, so here we have concluded dyslipidemia. You need to see the previous video as well to make sure that you have completed all dyslipidemia objective, the first part and the second part. Okay, now, on this side, there is 2021 Canadian Cardiovascular Society guidelines for management of dyslipidemia or prevention of cardiovascular disease in adults. Patient with clinical atherosclerosis, abdominal aortic aneurysm, LDL more than 5, the most with diabetes CKD should start it on statin therapy. You know, diabetes is a risk factor, CKD is a risk factor, LDL 5 is quite high, so that's a risk factor. So you have to give statin. That makes sense. Lipids and lipoprotein screening is recommended in more than 40 years at any age for those at risk, increased risk. And who are at risk? Let's say have familial hypercholesterolemia and the family has genetic disorders. Non-HDL cholesterol ApoB are preferred to LDL-C as lipid parameters for screening a patient with triglyceride more than 1.5. Lipoprotein A should be measured once a patient's lifetime as part of initial lipid screening to assess cardiovascular risk. Lipid lowering therapy should be intensified with ezetimibe, PCSK9 in patients with LDL-C more than 1.8, HDL more than 2.4 on maximally tolerated statin dose. Okay, so this concludes dyslipidemia. I hope you like this video. Please do subscribe to my channel to follow up with videos. Thank you.